inauguration of a 76th International Virtual Learning Series titled on novel polymeric mucoadhesive buccal drug administration in association with the Indian Pharmaceutical Association, South Tamil Nadu local branch, head office at inauguration of a 76th International Virtual Learning Series. We are proud to have an eminent titled on novel polymeric mucoadhesive buccal drug teacher, administrator, researcher, and honorable association with the Indian Pharmaceutical Association, South Tamil Nadu local branch, head of faculty of pharmacy, inauguration of MAHSA University, Malaysia, international virtual learning. We are proud to have an eminent, valuable part of this wonderful session. Novel polymeric. It's a great pleasure for all of us, teacher, time to be administrator, researcher, and honorable association with the Indian Pharmaceutical Association, South Tamil Nadu. Great honor for us and head of faculty of pharmacy, inauguration of MAHSA University, Malaysia, international virtual learning. We are most welcome, valuable part of this madam. Most welcome, madam. Novel polymeric. It's a great pleasure for all of us. Finally, I welcome all the professor, faculty members, my dear enthusiastic students for today's session. So it is gratifying to note that this session cover wide range of interesting topic relating to the novel polymeric mucoadhesive buccal drug administration. So I hope this session will be a good platform for our students. So students, kindly utilize this great opportunity to explore your knowledge. This is the first and foremost needed for your career. All the very best, my dear students. Once again, I welcome you all. Thank you. Thank you, madam. Most welcome, madam. You can proceed your presentation, madam. You can start, please.
Okay. Good afternoon to all. Thank you very much for this opportunity. I would like to convey my thanks to Alathilingam College of Pharmacy and convener and principal for this wonderful arrangements. I take this moment to talk about novel polymeric mucoadhesive buccal drug administration. Oral drug delivery, everyone knows the most popular route of administration is oral drug delivery system. Most of the drugs administered is the most available and popular and preferred route of administration. There are a lot of problems associated with this administration, that is enzyme integration and gasification. So what this will do with the drugs? Actually, when we take the drugs, they get wasted as a metabolite. And the enzyme present in the intestine and get the drugs. And gastric, there is a possibility of... Hello.
Madam, there is a little issue in audio.
Oh, you can't hear me, sir? You can't hear me?
No, we can hear you, but
okay
yeah, it's okay now.
Okay now? All right. All right, okay. So this is my story. So what is the delivery system? So majority of the oral. But there are a lot of problems associated with this oral administration. That is metabolism, enzyme integration, and gasification. So what this problem will do with the drugs? Usually the drugs which goes to the liver, there it gets wasted as a metabolite before getting into the blood circulation. And the enzyme present in the stomach and also the gastric irritation of the drugs also possible. Hello? Yes, sir.
Yes, madam. There is a disturbance in your speech, madam.
Oh, really? You can't hear me, sir? You can't hear me?
We can hear you, but it was not in normal mode, somewhat in extended mode. Your voice is in extended mode. Now it's okay. When you are presenting, some little bit extension was there.
Maybe
yeah, maybe audio எதுவும் ப்ராப்ளம் இருக்கலாம். இல்லாட்டி நீங்க ஹெட்ஃபோன் மாட்டினீங்கன்னா சரியா மாட்டாம இருக்கு, ஜாக்கிரதை மாட்டாம இருக்கு.
இல்ல மாட்டிட்டு தான் சார் இருக்கு. I think we fixed it properly. 1 second, so maybe once
இல்லாட்டி நீங்க ஹெட்ஃபோனை ரிமூவ் பண்ணிட்டு கூட பேசுங்க மேடம். மேபி ஏதோ இஷ்யூ இருக்கு. லிட்டில் நீங்க பேச இழுக்கிற மாதிரி கேக்குது மேடம்.
இழுக்கிற மாதிரி இப்போ சார் இஸ் இட் ஓகே ஃபார் மீ?
now ஓகே. ஒரு 2 minutes ரிலீஸ் கழிச்சு அகைன் கொஞ்சம் எக்ஸ்டெண்ட் ஆகுது.
அதே மாதிரி தான் வருதுங்களா? அதே மாதிரி தான்.
ஆமா 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 மேடம்.
என்ன ரீசன் தெரியலீங்களே.
ஹெட்போன் ரிமூவ் பண்ணிட்டு கூட டைரக்டா பேசுங்க மேடம். சில சமயம் அந்த மாதிரி கரெக்ட் ஆயிடும் மேடம்.
ஆல்ரைட். ஆனா அந்த அளவுக்கு ஆடிபிளா கேக்குதுங்களா இப்போ?
எஸ் மேடம்.
Audible? Is it audible?
Yes, madam. Yeah.
Okay, sir. So let me continue. Hello.
Madam, again, அதே பிரச்சனை வருது மேடம்.
Again, அதே problem, sir. Just maybe because of aircon. Just a second. Maybe.
Okay, madam.
Is it okay now? Now, okay.
Again, it continued.
Again, it is continuously same.
Yeah. You have sufficient network, madam?
Yeah, we have Wi-Fi, sir. Actually, we have Wi-Fi connection at home.
A slight disturbance still there, madam. Whenever you are speaking continuously on a particular part, it gets extended, madam, after 1 or 2 minutes. No, yeah, madam. Again, it continues, madam. Can you switch off and you can start again, madam? It will maybe sometimes it will make you.
So you want me to stop sharing and continue from the beginning?
It may be a possible. It is also possible.
Alright. Okay.
Yes, madam. Yes, madam.
Hello.
Yeah, I can
Now
hear
is
you,
it clear,
madam.
sir? Now is it
Yeah,
clear?
clear, madam. Clear.
Okay.
Yeah.
Okay. So the video, shall I turn video? Am I face can
Yeah.
able to see?
Madam, I think without video it will be better, madam, because there is something in network connection only, madam.
Um,
You can proceed, madam.
so now,
Without video, you can proceed.
all right. Okay. No problem. Mm,
Again, there is a little bit disturbance.
little bit disturbance. Maybe again. Okay. Is it okay?
Yeah, there is a voice scattering, madam. Voice is scattering.
I think legal
Yes, madam. We can't get you clearly.
Can you hear me now, sir?
Yeah, yes, madam. Yeah, we can hear you.
No, sir.
Again, there is a disturbance is there, madam.
No, sir. No.
Yeah, I can
Now
hear you
again.
clearly. Now
Now
it's
you
okay.
can.
And
Now
now
it's
okay.
okay.
Yeah, now okay, madam.
All right, sir. Okay.
Okay, madam.
Shall I continue now?
Yes, madam. Proceed, madam.
All right. Okay. Sorry for the inconvenience caused because maybe due to the connection. I will just say it again. So today I'm going to talk about the this is the title, the novel politics of administration. So we know the overall administration is one of the most popular and preferred law administration.
Madam.
Yes, sir.
Yeah.
Cannot hear.
Yes, madam. It's not clear, madam. You can do one thing, madam. You can connect that through your audio through your mobile, madam. You can open the link through mobile. You can talk as it is, madam. Then video can be connected with the computer, madam. That will be better one for you.
I don't understand what you're trying to say, sir.
Madam, you can keep that PowerPoint in computer itself, madam. It start working on that and talk it through mobile, madam. I think there is a problem in your audio jacking, madam. Audio jack, there is a problem. I think so.
All right.
Sorry, madam. I can't hear
You
you.
want?
Yeah, you can. Yeah, you can connect it. Join the meeting through mobile, and you can speak it through that, madam.
No, sir. Now is it clear, sir? Now can you able to
Now,
hear me?
yeah, now it is. Yeah, now it is clear,
All right.
madam. Now it is
I'm
clear.
talking directly instead of using microphone. Better I
Okay,
directly I'm talking, sir.
okay, madam. That will be better, madam. Okay,
All
madam.
right. Okay. Okay. If you all can hear, no problem.
Okay, madam.
All right. Sorry again. Sorry for the inconvenience caused because of internet connection. Today I'm going to talk about novel polymeric administration. Even the oral drug delivery system is one of the most popular and preferred route of administration. However, there are still a lot of problems associated with this route of administration. There is hepatic phosphorus metabolism, hydrophilic degradation, and gas degradation. So this is the main drawback. Hepatic phosphorus metabolism, what will happen? If you take drugs, it will get as a metabolite before going to reach the enzyme present in the liver. And the enzyme in the GIT tract and stomach also may degrade the drugs. And some of the drug may causes the gastric irritation. So these are all the drawbacks associated with it. Then what is the alternative? The buccal route of administration is the best alternative to overcome all these issues. The first and the foremost the advantage of the buccal drug delivery system is the drug dose is very low. It is the low concentration of drug. It needs to be therapeutically handled for long hours. Then the buccal delivery is one of the best alternatives for the long periods. There are many advantages associated with this buccal route. The buccal area is highly vascularized, so the absorption is maximum possible. And one drug delivery because it can be able to high contact time, so that the drug can stay longer time in the buccal cavity in the form. And the low enzymatic area, so we need to worry about the enzymatic activity of the in case of any problem or any issues, in case of any emergency, we can terminate the medications and we can avoid the fluctuation in the rate of concentrations. And this avoids the hepatic phosphorus metabolism. We can be able to improve the bioavailability and it is painless delivery and easy to apply and sterile technique is not necessary. And even this dosage form can be able to administer to the unconscious and helpless patients. So these are the lot of the main advantages associated with the buccal drug delivery. If you look at this picture, you can see clearly here. This is you can see the application area. You can see the above the lower lips. Here you can see the application of the tablet, and this is the below the upper lip. You can see here. And in this picture, you can see clearly the administration can be done here in the buccal cavity near the cheek area and the gingival area. Okay, these are all the application area where we can apply our medications. All right, you can see here the beginning the application of the medication. You can see here the swelling of polymer is very minimal, but when times goes on, after look at here after 6 hours. You can see here the swelling of polymers are more, meaning that the saliva present in the oral cavity, which can be able to swell the polymer, so that the polymer can strongly bind to the mucosal membrane here, so it can stay longer time. So this is the main important point we need to consider. The mucoadhesion with the mucosal membrane is a key element we need to consider when we making the buccal formulations. So if you look at this table column, you can see there are a lot of marketed products available. Prochlorperazine, fentanyl, glycerol, trinitrate, meconazole, testosterone. These are all the different marketed available tablets for treating different conditions, nausea, vomiting, and it will reduce the pain. The fentanyl, especially the fentanyl is which is one of the very good innovation in the buccal area, which is available in the form of film and tablet, mainly used to the severe pain associated with the cancer. And also antifungal meconazole is also available. So the buccal drug delivery not only suitable for the systemic drug delivery, and also it will be suitable for to treat some local condition in the oral cavity. Example, some oral ulcer, some fungal infections, even any other the periodontal diseases. This also can be treated by using the buccal formulation. So that is the one good advantage of the tablet. This buccal formulation is to reach the systemic circulation as well as to treat the local conditions present in the oral cavity. You can see this is the different marketed product. The packages you can see here. As I was telling earlier, You can see here the miconazole tablet, prochlorperazine, fentanyl, different concentration, 600 mcg, 775 mcg. You can see these are all the marketed available dosage form. All right. So, what is the route of absorption? So, when you apply this buccal dosage form in oral cavity, as I mentioned earlier, the buccal dosage form can stick to the mucosal membrane. So, the drug in the dosage form can travel through the different route. One is the paracellular, another one is the transcellular route. What is paracellular? Paracellular is nothing but it can able to travel through the intracellular space between the cells. Just you have to imagine, just you have to note it down. This is the between the cells. Mainly hydrophilic drugs able to travel through this route. When it comes to transcellular, the drug can be able to travel across the cell. Means it can travel through the cell. Mainly the lipophilic drug can able to travel this route. Okay, this is the two major absorption route. So, as I mentioned, mucoadhesive or bioadhesive. So, if any one of you want to make dosage form in this category, you need to mainly give more importance to mucoadhesive, because if there is no adhesion on the mucosal membrane, there is no point of making the buccal drug delivery. So, the mucoadhesive. So, the selection of polymer is very, very important, especially when you're choosing the hydrophilic polymers. That polymer must be having the good adhesion to the mucosal membrane. So majority of the mucoadhesive will be gained through the using the hydrophilic polymers. Hydrophilic polymer is nothing but just the polymer can able to soluble in the water. So what happened? How the mucoadhesion, how the mucoadhesion bond will be happening with the mucosal membrane. So when you take the polymer, the dosage form having the mucoadhesive layer, which is made up of hydrophilic polymer. So what happened when it contact with your mucosal membrane? Because of saliva, it gets welled. So you know very well all the polymers having a hydroxyl group in its structure. Then our mucosal membrane, the mucin is present in our mucosal membrane, the hydrogen molecule present in our mucin. So the hydrogen in mucin, hydroxyl group in the polymer, which can able to form the strong hydrogen and hydrogen bond, which is a strong covalent bond, so that the dosage form can able to stay longer time, which causes the high rate of intimacy between the mucosal membrane and the dosage form, so that we can maintain the dosage form for 4 hours or maybe 5 hours or maybe 6 hours. So that is a very key important point. You need to note it down, the mucoadhesion. So in comes to dosage form, there are different variety: film, tablet, patches. You know, lot of different dosage form available in the buccal drug delivery. Today, just I am going to talk about buccal film and buccal tablet. I have chosen atenolol is a model drug. The reason why I chosen this drug is atenolol is a beta blocker, which is mainly used to treat hypertension and also angina. So this is why we have chosen this drug. As I mentioned, this drug delivery is mainly for to improve the bioavailability, and as well as it is highly suitable for low concentration of drug. I mean the low dose of drugs. So for that reason, we have chosen this as a drug delivery. So atenolol, if you look at this, as I mentioned, it is a beta blocker treatment for hypertension, angina, and the bioavailability of this drug is just between 40 to 50%. That is due to the high phosphorus effect. So let's see in this topic how we are going to make as a buccal film and buccal tablet by using the atenolol. So before starting up any work, there are the proper flow of the execution of work. The first step is pre-formulation study. Then the formulation. Once we make formulation, we can go to the evaluation. After that, we can do the that is a film. Then when making the tablet, again we have to formulate a tablet. After making a tablet, we have to do all the quality control tests. Then finally, we can make whether the tablet is meet the requirements according to the pharmacopoeial limits or not. Okay, right. So as I mentioned, preliminary studies. So before making any dosage form, this is the compulsory study. You need to know, you need to do whether the drug and the polymer are compatible each other or not. So you don't know whether that ingredient, each ingredient, when we mixing together, what will happen, we don't know. So before, after making tablet, after making come to any conclusion, before that it is better to do to check whether it is compatible each other or not. So what we do is, this is the first study, is the physical observation. So here, usually we take drug and polymer in 1:1 ratio, keep it for 1 month. Every week we need to check it for any physical changes, like any color changes or any morphological changes, or any the physical changes, like the solid become liquid, or any dark color, whatever. So the morphological changes and physical changes we need to observe every week. So usually this sample will be kept in wire at 40 degrees Celsius and 75% relative humidity. Every week we need to check it whether any changes or not. If there is no characteristic changes, then we can confirm that there is no interaction. Physically, there is no interaction between the drug and polymer. And okay, the physically we confirmed, okay, it is compatible each other. Then how do we know, is there any chemical incompatibility between the drug and polymers? How do we know? So there are another test that is known as FTIR, that is a Fourier transform infrared spectroscopy. You can look at here, this picture here, the FTIR spectrum of drug alone and the FTIR spectrum of polymers alone, and the mixture of drug and polymer together. So we, after taking this IR spectrum, we have to compare our spectrum with the controlled sample. So if there is no changes in the peak when compared to the control sample in the sense standard sample, if there is no changes in the peak, then we can confirm that there is no chemical interactions between the drug and polymer. Okay, how do we know? Okay, is there, if in case any interactions between the drug and polymer, how do we know? Definitely there will be changes in the peak because of the forming of new functional group. Usually any interaction will happen, it can able to form different functional group, so that you can obtain different peak. So from that you can compare your sample with your the standard sample, and you can confirm that there is no interaction chemically between your drug and polymer. All right. Then the another study, this is also coming under preliminary study, that is the DSC, differential scanning colorimetry. So again, the individual drug and polymers, and as well drug and polymer together, you have to take the DSC thermogram. Again, you have to compare your sample with the standard sample. If there is no changes in the thermogram, then you can confirm that, okay, the chemically, again, the sample, the drug and the polymer are not chemically incompatible, so that you can choose this drug and polymer for further formulation steps. So this is the 3 preliminary study we need to know for selection of your drugs and polymers. Okay, after selection of drug and polymer, you know very well the atenolol is your pure sample. This is using this you are going to do your research work. So you need to do the calibration curve, otherwise known as the standard curve. Just serial dilution of sample, and have to get the absorption from the UV visible spectrometer. Then you can plot the graph between the concentration and absorption, and you can find out the R-square value. So this data is very important for you to calculate the dissolution drug release, dissolution drug release, even the content uniformity studies, even the animal study, even whatever the study future you are going to do, that you can correlate with this standard curve of atenolol. So this is the also important preliminary study you need to do. All right. So now all the preliminary studies over. Now we are moving on to how are we making the buccal film? What are the what are the ingredients? What are the different excipients we are using here to make the buccal film? Look at here the different component here, the drug and HPMC, SCMC, sodium alginate, PVA, propylene glycol. Look at this. These are all the primary layer. Usually the film having 2 layers. One is the primary, the another one is the secondary layer. The primary layer is nothing but it contains the drug along with all the hydrophilic polymer. If you look at here, this is the hydrophilic polymer. There are different formulation. Maybe you can see here F1 to F12. Here I didn't mention the atenolol dose. This is just model. Maybe you can use atenolol dose. Different doses there: 50 milligram, 250 milligram, 200 milligram. Even the pediatric dose is 25 milligram. Different milligram is there. So you have to choose your dose. The different dose of your different concent. I mean the concentration of atenolol along with the hydrophilic polymer. And you can see here the propylene glycol and distilled water. So this is the ingredients used to make the primary layer, which is a mucoadhesive layer. So as I mentioned, hydrophilic polymer can able to make the mucoadhesive layer of the film. Next, you look at here the secondary layer. The secondary layer is nothing but using the ethyl cellulose. This is the hydrophobic polymer, which is not soluble in water. So it can make the backing layer of the film. You can look at this picture, you can easily understand. See here, this is the Petri plate. I use the Petri plate, the mercury used as a substrate. Look at here the clear solution of backing layer. Ethyl cellulose dissolved in, ethyl cellulose is a hydrophobic polymer, dissolved in dichloromethane and methanol, organic solvent, and make it clear solution. Then this clear solution transfer over this mercury substrate. You have to wait for few hours. Then it makes the, after evaporation of organic solvent, it can able to make this film like this. Okay. Then, so this is the backing layer already we made it. After that, you look at this one. This is the beaker containing the polymer, that is the mucoadhesive polymer, or the SCMC or maybe HPMC, whatever. That polymer dissolve in the water. In that, propylene glycol must be added. Propylene glycol acts as a plasticizer of the film. And also you need to add your drug, the required amount of the drug, and mix it thoroughly to ensure not present any air bubbles inside it. Okay. Then this will be transferred over this already pre-formulated backing layer. Okay. So what you have to do, once we transfer this to about this, you have to keep in the oven for maximum 12 to 18 hours and 50 degrees Celsius. So water after that, what happens? The water will be evaporated because this layer is having this solution. So water usually takes more time to evaporate when compared to the organic solvent. So what happens once we transfer over this backing layer? It takes long time, maybe around 12 to 18 hours. Once it gets evaporated, then it can have this. This is the bilayer. Why bilayer? Because already the backing layer we made it. Again above that, this one we transfer on above the backing layer. Again the mucoadhesive layer formulated, so that it is known as the bilayer buccal film. Then you may wonder, oh, the film size is very big. How can we apply this on? Actually, this petri dish, the size is 9 centimeters. The diameter is 9 centimeters. So what you need to do is, this 9 centimeter diameter of the film, you can cut into 2 centimeter in diameter. So each 2 centimeter in diameter film having the required quantity of the dose of the atenolol. So in such a way, you should calculate the drug. So totally you should calculate, okay, this total 9 centimeter, how many 2 centimeter film can be, 2 centimeter diameter film can be made. Accordingly, how much amount of drug we can add. So all the dose you have to calculate and add it together, because we are making a big film. In that we are cutting into the small pieces of the buccal film. That small piece only we are going to apply to the patient. Okay. So this is the buccal film. All right. So after the manufacturing of the film, as usual, like tablet, we need to do all the quality control tests for the film as well. So film weight, the drug content, thickness, these are all the common usual tests. But here, if you look at here, the surface pH, swelling index, and ex vivo residence, which is quite unusual when compared to the tablet quality control test. So what is that? Why we need to do this test? Surface pH. When we apply the film on the buccal cavity, there is a possibility of irritation there, because due to the changes in the pH of the film when compared with the buccal pH. So that is, it is mandatory to check the pH of the film, surface pH of the film, which must be nearing to the 7 neutral. So the salivary pH also between the range 6.2 to 7.1. So if within that range, the film surface pH also will be within that range, so that it won't cause any irritations or any allergic reaction towards the film. When moving on to swelling index, the swelling index is done usually will be keep on the agar hot agar solution. I have to transfer into the petri plate. I have to wait for some time to get solidified. Then later on, we have to move the film on the swelled agar. I mean the solidified agar medium, so that from the agar medium the water can be able to go into the film, and so that the film can absorb the water, so that we can check whether how much amount of the water can be absorbed by the film. That just we can do with the help of hot agar solution. And next one is the X5 residence time. So this is again key test, because after doing all this, if your film is not staying long time in your cavity buccal membrane, then it will be issues. Okay, so the resident time is very important test. If you so there is X5 resident time. I'll show here. Look at here. This is the beaker. In that, just have taken the phosphate buffer pH 6.8, which is similar like salivary pH. A freshly cut porcine buccal mucosa got from the slaughterhouse. The 2 centimeter size of the film stick to the buccal mucosa here. This buccal mucosa attached to the water adjacent space, which is that whole setup is immersed in the hospital. And we have monitored for around 8 hours. So the time taken for detachment of the film from the known as X5O residence time. So this is, you need to compulsory, when you making the film, you compulsory you need to do this test. Then only you can predict whether your formulation can be able to stay longer time on your buccal cavity or not. So this is one of the key tests you need to do. So after that, you can see here, this is a folding endurance. Folding endurance means the film you need to fold it in the same place for 200 times, and you need to check whether the film is flexible or not, whether it is breaking it or not. What is that endurance of the film? You need to check it out. And PMA is a percentage of moisture absorption. So you need to check the film stability in highest, the highest moisture condition, whether the film is stable in the high moisture condition or not. And the PML is nothing but percentage of moisture loss. So again, this test is useful to check the film integrity in high dry condition. Okay, the percentage of moisture loss in dry condition, whether the film is holding its integrity or not. So for that, we need to do this test by using the aluminum chloride and the calcium chloride in the desiccator. We need to keep it for 3 days. Again, before keeping inside the desiccator, you need to check the initial weight. After that, again, you need to check final weight. Then using the formula, you can calculate the percentage of moisture absorption and percentage of moisture loss. Okay, so these are all the important tests you need to do. And then, okay, then drug release. Drug release, from our formulation, from our film, the drug, how much amount of drug is releasing in periodic time interval, we need to know. So using the dissolution apparatus, we need to do this test. Like tablet and capsule, how we do the same way, we'll do it for the film also. But here the medium is again phosphate buffer medium, because which mimic the saliva conditions, so that we are using the phosphate buffer. You can see the graph plotted between the time in minutes in x-axis and cumulative percentage drug release in y-axis, so that you can see the drug release almost more than 80% of the drug release at the end of the 5th hour. So this is the test you need to do it. Then you can see here QPG model and Coase-Mayer-Pepos model. So very important test you need to know. In order to know the drug release mechanism and kinetics of drug release, you compulsory need to do the Hokiji model and Coase-Mayer-Pepos model graph. You need to draw it. I mean, you need to do it. By using the square root of time in x-axis and cumulative percentage drug release in y-axis, you can see you can get the graph like this. And you can see this graph Coase-Mayer-Pepos model. Coase-Mayer-Pepos, which is plotted between the log time in x-axis and log cumulative percentage in y-axis. So by plotting this graph, you can identify whether your drug is zero order drug release or first order drug release, and also you can identify whether the drug release mechanism is a Fickian drug release or non-Fickian drug release or carrier transport mechanism. This is you can identify from the exponent value n from the graph. Okay, so this test is mainly useful. This graph is mainly useful to identify the drug release mechanism and also the release order. So you have to definitely have to do this if you want to really know whether it undergo the Fickian and zero order or non-Fickian or first order. All this you have to identify, means you have to do this graph. All right. Next, moving on to ex vivo permeation studies. Okay, so we done already the dissolution, the other physicochemical test. But how we confirm whether our drug is permeating through the mucosal membrane or not? How much amount we when we do in vivo study only, we will completely confirm. Okay, our physical chemical test and all the value are really fit into the in vivo study model as well. So if you look at here, this XYY permeation also will be done with the help of first porcine buccal mucosa using the France diffusion cell. Usually there will be a donor and receptor compartment, and the film attached to the porcine buccal mucosa will be clamped between the donor and the receptor compartment. From the receptor compartment, the sample will be taken and will be analyzed by using the UV visible spectrometer at 226 nanometer for atenolol, so that you can calculate your drug release comparing with the standard curve of atenolol. And again, as I mentioned, okay, physically we know when we do surface pH test with the help of electrode, pH electrode, we can say that, okay, our formulation is within the range which do not cause any irritation to the buccal mucosa. But when you do, unless you do the animal study, you can't, ex vivo animal study, you can't completely confirm. So that is necessary, we go for the histopathological examination studies. Just what we do again, after applying the film on the porcine buccal mucosa, we have to wait for a few hours, 4 hours or 5 hours. After that, we take the porcine buccal mucosa and we have to process it with the formalin, and the hematoxin, iosine. These are the different agent for doing the histopathological studies. After doing it, we have to, using the camera, usually histopathological study, we have to send to the particular university, they will send us the report. We usually, personally, we don't do that. Just we will send the sample to them. They will do us and we have to pay for that. That's it. So this is the report of the histopathological examination, and you can compare your tested, I mean your atenolol treated porcine buccal mucosa with controlled buccal mucosa. So you have to check the morphological, is there any morphological changes or any changes in the surface of the, the picture. You can compare the morphological changes of the picture. You can compare your test with the control, so that you can identify is any changes or not. So this is the important test as well. All right. Then after that, moving on to all this test has been done. Next step, moving to the in vivo animal study. So this is like before giving to the going to the clinical trial, that definitely we need to do it in the animal. So the animals here we choose usually rabbit, healthy New Zealand male rabbit we will choose for this study. So usually here the group will be divided into, one group is control, the another group is the atenolol oral solution treated group, the another group is the film treated the group. Then from the marginal ear vein, the blood sample will be withdrawn for periodically. Then then it will be centrifuged in the the centrifuge, and the plasma sample will be taken. And from that, using the HPLC, we can calculate the the bioavailability of the drug by using the different software, the SAS software and the trapezoidal rules. Using those things, we can calculate the estimation of amount of the drug in the plasma. Right. So from that, we can confirm whether the drug is really absorbed in the the amount of the bioavailability of the drug is more when compared to the oral administration of atenolol. All right. So now after all this test done, the next step, moving on to the stability studies. The stability study, just we have to conduct for 3 months. Again, the 40 degrees Celsius and 75% relative humidity according to the ICH protocol. And after 3 months, again, you have to check all the physicochemical study, especially for its physical appearance, folding endurance, drug release, spelling index, content uniformity. All this study have to do it again and have to compare the results with the previously results. And if it is not significantly different, with statistically not significant, then the product is highly accepted. And And the correlation study, okay, you know the in vitro release, the drug release, and also you know the ex vivo drug release. So you have to compare these two. You have to correlate these two drug release, and you can compare how much it is correlated each other. So this is the in vitro and ex vivo correlations. Okay, so this is the okay. So now the film, the complete study is over. If you want to make a film, make sure you do the preliminary studies to select the drug and polymer. After that, formulate a film. Then after that, go for the physicochemical evaluation. Once physicochemical evaluation is done, then you go for the ex vivo studies, that is ex vivo resident studies and ex vivo permeation study. Once those studies completed, then you can move forward to the in vivo animal study. Then the in vivo study completed, then you can correlate all the results, and you can identify whether your formulation really better when compared to the oral conventional atenolol tablet. All right. Okay. Next, the same film, we can make it the bilayer buccal tablet. Same, there we are using the solvent, all those things, because it is film. But here, like normal tablet, here we use the magnesium stearate, talc, mannitol, all the other excipients like you know very well, the diluent, disintegrant, glidant, lubricant. All this is the important excipients for to making the tablet. So these are all the ingredients we have to use it. And also the secondary layer, the same model. This is looks similar like the film, but here the only the ingredient is different. Otherwise the procedure, everything same like film only. So what you can do is, here you can, by using the compression machine, usually you have to weigh all the ingredients. First you can compress your backing layer. After that, above that you can add your mucoadhesive layer, drug plus other polymers, magnesium stearate, talc, all those things. Again, you have to do second compression, so that you will be having the bilayer tablet. Look at this picture. You can clearly understand the two. Look at here, this picture, this tablet. You can see the two distinct layer. One is the colored one, another one is the white color. The reason why we add the coloring agent, to differentiate the backing layer from the mucoadhesive layer. Just pinch of coloring, comfortable coloring agent, you can add it, so that you can identify the two layers. Then again, the mucoadhesive layer just attached to the buccal membrane. Just that the mucoadhesive layer should face towards the mucosal membrane in the oral cavity, so that the drug will be released from the buccal tablet. You look at this. This is the clear this. So this is the layer, the bilayer. So first I add ethyl cellulose and compress it. Above that, add the mucoadhesive layer. I mean the drug with all polymer and coloring agent, and try to compress again, so that the bilayer tablet will be formulated. Okay. So then the mucoadhesive must be towards the mucosal membrane. You may wonder why we need two layers. What is the purpose? I'm telling you, the reason for adding the backing layer, to prevent the drug loss in opposite direction. Opposite direction in the sense, when you apply on your buccal cavity, there is a possibility of drug release in opposite direction, means towards the oral cavity. Maybe it can mix up with the saliva and you can able to swallow it. So that the drug again going to reach into the GIT, again it will goes into the first cause effect. So to preventing the drug loss in opposite direction, I mean the drug moving from mucoadhesive layer to the saliva, we introduce the backing layer. So the backing layer is like kind of plastic membrane, because it is a hydrophobic membrane. When you apply on oral cavity, which is unable to soluble in saliva, so that the drug release only towards the mucosal membrane. So the drug release will not be in backing layer side, so that the drug will not come up to the saliva, so that we don't waste the saliva. So this is one of the great advantage of one of the great and foremost in favor of the buccal drug delivery advantage. Then again, if you see here the chemical tests as usual, the hardness, thickness, friability, surface pH, weight variation, these are all the tests we need to do as usual, like other conventional tablet dosage form. Look at here again, the surface pH, you need to do it to check whether the pH is within the salivary range or not, to check the irritation of the tablet. Maybe the tablet should not cause any irritation on the mucosal membrane. As usual, again, the in vitro drug release by using the dissolution apparatus. And yeah, that's it. Then all other tests like XYO permeation studies, again the XYO residence time, again animal study, everything similar like the buccal film. Only the difference is that is a film formulation, this is a tablet formulation, but the test remains same. The tests are not changed, the test remains same. So you can follow all the tests whatever you followed for the film. So from that, what we can conclude is, so the film and tablet of atenolol will be formulated by the solvent casting. The technique I told you right in the beginning of my talk, I told you the mercury used as a substrate, the different steps I explained you, right? So that technique is known as solvent casting technique. And the tablet formulation that directly doing the compression, right? Simple compression machine using 2 times compressing the powder material, that is known as direct compression techniques. So this is the way we are using for making the film and tablet. After that, what we done, all the test is done, and also the in vivo release profile we have done using the animal rabbit. After that, we have to compare the XYO and as well as the in vitro correlation study also done. So from that, we can easily identify atenolol is a good choice delivered through the buccal route of administration in order to increase its bioavailability, minimize the dose, and also reduce the side effects, and it may improve the patient compliance. So this is the conclusion of the talk. Yeah, thank you very much.
Thank you, madam. Any questions?
Yes, please. Any questions? Welcome.
Madam, you have told this buccal adhesive generally unidirectional for the benefit of the patients.
Yes.
But when we see the thickness, when we see the thickness, there are some of the part it does, which was not adheres to the surface of the buccal mucosa. When they was exposed to saliva or water, there will be a chance of drug release, na, madam. So
Yeah,
how we can overcome that?
yes, sir. That's why let's say we make sure the mucoadhesive layer attached to the mucosal membrane. I mean, when you put in your mouth, make sure that mucoadhesive stick to the your mucosal membrane. So the mucoadhesive layer only having the drugs. Backing layer doesn't have the drug. So the backing layer here, the function of the backing layer is to prevent the drug loss in the opposite way. It won't come to your saliva. So only the drug release from the mucosal layer to your mucosal membrane, so that the drug release will not be there in the backing layer. So we can prevent the drug loss. Opposite way of drug loss to your saliva.
Okay, madam. And the second question is, so we are using 500 ml as a dissolution medium.
Yes.
So normally in buccal, we are not going to be exposed that much volume of fluid. So when you're keeping it in within the dissolution medium, how it was correlated with immune release?
Yeah, usually the production of saliva per day in human is 1 to 2 liters. You may think that okay, at the moment if you check your saliva quantity is very low. Usually, throughout the secretion of saliva in human is per day 1 liter to 2 liters. So that is the reason why we have chosen 500 ml. Because we can't perform the study with the 5 ml or 10 ml. Of course, we can do that study, but still the secretion of the saliva in our human is 1 to 2 liters. Roughly, it is 1.8 liters around. So that is the reason why we are using the 500 ml. In fact, you can use 200 ml also. It doesn't matter. Accordingly, your dilution factor will be changed. That's it. If you are using 200 ml, then the dilution factor will be changed. If you go with the 500 ml, again, accordingly, your dilution factor will be changed.
Okay, madam. So when you are placing the buccal tablet or buccal film inside the mouth, so what will happen for the backing layer after 5 or 6 hours?
Yeah, that's all. Once the completely the absorption is over, sir, you can literally you can feel it that the mucoadhesive layer maximum we can tell patient that you can use only 4 hours or 5 hours because each yeah like that only we are using every medications one. Let's say if you are taking the paracetamol tablet, we say morning you take again afternoon again another dose in the evening, right? The same way. So when we instruct the patient, they may keep that formulation for 4 hours or 5 hours. Then after that, that just they have to discard it.
Yes, madam. Actually, whenever we are using a sustain release or control release, we want to release it. We want to cover for 2 dosage period, madam. So
Mm-hmm.
if we have it for only 4 hours, means like morning once and afternoon once, like that. That duration only will come, madam.
Yes.
Okay, madam. And if they took or they swallow the backing layer, what will happen?
Actually, that's what sir issue. Nothing will not be happen because it is a biocompatible polymer. In case by accidentally if they swallow also, it will not cause any dangerous effect to the human because it is biocompatible polymer. It will be just biodegrade, no issues. Usually no need to swallow, but actually if swallow also it wouldn't cause any issues because already the drug absorbed from mucoadhesive layer. So only the leftover portion is the backing layer, so which doesn't cause anything to the patient in case actually if they swallow also.
Okay, madam. Any possibility of corrosion on the mucosa, madam, like
No,
irritation
no,
or
that's what
redness,
sir.
skin damage?
That's what we are doing the study before. If any, as you mentioned, any possibility of the erosions, all those things, that is because of the changes in the pH of formulation causes the irritations. Some ulcerations are possible. That's why we make sure we have to do the pH study, the surface pH study, and also histopathological examination also we are doing it. By doing so, we can confirm, okay, if in case really the surface pH is very low, let's say below 5, below 4, below 3, something like that, or maybe it is greater than 8, means definitely whether it is acidic or alkali, definitely it's going to harm your buccal membrane. So that is the reason we need to maintain the pH is neutral around 6 to between 7, that range, because the salivary pH also between the range of 6 to 6.2 to around that 7, that range. So if our formulation also within that range, that then it wouldn't be any issues. In case if you go over like say above 8 or below 6, means definitely acidic and alkali pH, which causes the irritations to the irritation possible. I mean the erosion is possible to the membrane.
Thank you, madam.
Okay.
So there is a question from Mr. Raghavendran Telfambi.
Yes, please.
What are the major complications of buccal tablet?
I didn't get you. You mean the disadvantages or what?
Yeah, demerits. Yeah.
Buccal tablet, in case, let's say, sir, if you want to keep a longer time, means that the high dose of drug, unable to administer to the buccal cavity, that is the one of the thing. And also the surface area of the buccal cavity is very low, so the absorption will be minimized usually. If in case if you want to give highest dose of drug, then the surface area of a buccal membrane is low, so that would be the major drawback of this buccal tablet. Buccal formulation, any buccal formulation. Yes.
Okay, madam. And another question by Mr. Raghavendran.
Yes, please.
Buccal delivery is for adults or pediatric?
Buccal drug delivery is mainly suitable for the adult actually. Adult and even geriatric patient also. Pediatric patient, we make sure the children, accidentally should not swallow it. If they play with the formulation, maybe there is a possibility of swallowing and choking. So it is highly suitable for adult and geriatric patient. In order they will listen the patient, the instruction, the label they will follow. But children, maybe accidentally if they swallow, there is a possibility of choking.
Okay, madam. How the buccal delivery is differ from sublingual delivery?
Come again, sir.
And what
Buccal
are
drug delivery is?
differed from sublingual delivery because we are going to be have it in an intraoral delivery only,
Yeah.
and both of them are used to improve the bioavailability.
Yes, the
So, yeah,
bioavailability.
so Yeah, then so sublingual will be easy. So the patient can be kept under the tongue within a minute. It will be released. They can do the duty. Here they have to have it for a longer period of time. So there may be chance of irritation also. So why we have to prefer buccal delivery for some of the drugs, and how it differs from sublingual delivery, madam, based on the drug delivery.
Yes, sir. The sublingual drug delivery, that is below the tongue, we can keep tablet, right? If you look at the structure of the sublingual, is entirely different from the structure of your buccal cavity. Just lift up your tongue and you can check the under the tongue. You can check the sublingual membrane. You can see the thickness of the membrane is totally different compared to the buccal membrane. And also the absorption will be vary in sublingual category and also the buccal drug delivery category. Mainly majority of the cardiovascular drug will be formulated as a very quickly. Let's say if you want the therapeutic, instead of going for the controlled or sustained drug delivery, if you want immediate action, the sublingual route is the preferable route. If you are not focusing for prolonged or sustained or controlled drug delivery, then sublingual is preferred route, especially when it comes to the cardiac problems like angina pectoris, like nitroglycerin. These are all the very famous aspirin. These are all very famous sublingual tablet. Keeping under the tongue, the absorption will be very quicker and for a immediate effect. Usually the effect that is not meant for the control and sustain, but this one will be for the control and sustain drug delivery longer time. Yeah.
Okay, madam. Okay, madam. Thank you, madam. Dr. Venkatalakshmi, madam. Very thank
Yes,
you.
any no problem. You can welcome more questions. Welcome more questions.
Ma'am, good afternoon, ma'am.
Yes, please.
Ma'am, this is Arjun from AKCB, ma'am.
Yes, yes.
Yeah, I want to know the only one question.
Yes, please.
Especially in tensile strength. What is the role
I can't hear you. Can you speak a little louder?
Role of polymers in tensile strength, ma'am.
Come again, sir. Polymer?
Role of polymers in tensile strength for buccal films.
I really can't hear your voice. Something I can hear. Then tensile strength. You're talking about tensile strength.
Tensile strength, ma'am. If you are making a buccal films,
okay,
what is the role of buccal?
One second, sir. Maybe you can text me. You can message in the chat group. Chat. I can see the questions. Come again, sir. Can you just tell me again? It's a little louder. I can't hear you actually.
Role of polymers in tensile strength.
Role of polymer in
tensile strength, madam.
Tensile strength. In case of
tensile strength.
Tensile.
Sir, maybe sir, you can ask the questions and you can convey me.
Yeah, role of polymers in tensile strength, madam.
Role of polymer in tensile strength. Actually, I didn't present here regarding the tensile strength, shear strength, PS strength. Actually, there are the 3 different strengths we have to do it for the film. That is especially ordered. The instrument is there to check. Yes, sir.
Yeah.
So the tensile strength, shear strength, and the peel strength. These are all the 3 different strengths we need to check it for the buccal film when we formulating. Especially there is a separate instrument for that to check some weighing balance also. You can use it for the strength of the film. So you have to check it for each and every. For example, if you're making 6 formulations or 12 formulations, each formulation you need to check the tensile strength, and each polymer having the different tensile shear and the peel strength. Usually there is a grade. Generally, grass polymer, grass in the sense generally regarded as safe polymer. These are all the polymer usually having the good strength actually. But however, each and every polymer vary in their strength. So we have to do the test tensile, shear, and peel strength using the separate instrument, and we have to, usually the results will be in the Newton per meter square from that we can conclude which is having the good strength. So which is coming under the category of generally regarded as safe polymers.
Okay, ma'am.
All right.
Can we use a normal polymer for transdermal patch? Same as we can use in film, ma'am?
Yes, I will like you can use any polymer, any hydrophilic polymer. For example, sodium carboxymethyl cellulose, sodium alginate, polyvinyl pyrrolidine, propylene glycol, methyl cellulose. Lot of polymers are there. Any hydrophilic polymer you can take and you can dissolve in the water properly, very nicely. You have to mix it up. Along with that, you have to add your drug and the propylene glycol. Then you transfer into, you have to use any substrate. Directly you cannot transfer to the battery blade. You may use any substrate like mercury, as I said earlier. Just transfer onto the mercury. Then you have to wait few hours. Then it will get evaporated. The water get evaporated. You will get film. But if you want to make a backing layer, then again you have to go with the ethyl cellulose using in organic solvent. Again you have to add together. You can make it the bilayer film actually. Yes. Okay. Any hydrophilic polymer you can use actually to making the film.
Okay, ma'am. Thank you, ma'am. Thank you.
Yeah, and also concentration of the polymer plays very important. Simply if you put any concentration, you won't get film. The concentration of the polymer plays very important role when you make the film.
Okay, ma'am.
Yes.
Thank you. Thank you.
Thank you, madam.
You are most welcome.
Thank you, madam. Madam, thank you, madam. I hope this interaction, madam, presentation will motivate the student and encourage them in active learning of buccal drug administration.